Hey everyone, we are back at ASRM 75th conference here in Philadelphia, Pennsylvania. I am really excited to be with just one of the most visionary clinicians out there, Dr. Steve Nakajima from Stanford. Stanford comes with its own cachet in being Stanford, but you're pioneering a lot of new techniques in this field. And I'd like to start with addressing what are some of the actual standard treatments that are already offered if a couple's been struggling to conceive. When they come into an IVF clinic, what are the treatment options that they're going to be offered today?
So we talk about people as being infertile if they've tried for 12 months of effort and they haven't conceived. And so the first thing that we do if a couple meets that criteria is we might consider intrauterine insemination. It's where we go ahead and take the husband's sperm or the partner's sperm, purify it of impurities, and then go and place a small concentrated sample in the uterus at a time when the egg is in the fallopian tube, and then we try to increase the chances of the likelihood of that sperm and egg meeting. That's the simplest, intrauterine insemination.
Okay. Who's a candidate for that?
So almost everyone is a candidate if they have open fallopian tubes. That's the major thing. If you have a blocked tube and the end of the tube can't pick up that egg, then you're going to have problems. And so if we know that you have open fallopian tubes and your husband has reasonable amounts of sperm or your partner has reasonable amounts of sperm, we can go ahead and try that.
What's reasonable amounts of sperm,
though? Well, that's just it. Intrauterine insemination is one of those situations where the semen evaluation comes to life, because you can look okay on a semen analysis, but when we wash the sperm, not all the sperm survive, and therefore we like to have at least 5 million total motile sperm going in the uterus.
Got it. Okay, that's really helpful. And these days, as women are going on to message boards and coming onto our platform, and they're saying my husband has low sperm count, and they're seeing numbers that are below 10 million. They're sometimes 3 million, sometimes they're 1 million, sometimes they're 7 million. And so 5 million would be the thing that we're saying, at least 5 million, and you could try IUI first.
And remember, total motile sperm going in the sample that we're inseminating.
Got it, because they still need to swim in order to get there.
That's right.
So even though they're in the right place.
And we need a kind of a critical mass.
Yeah, got it. Okay, that makes a lot of sense. So if IUI doesn't work, or if they're not a candidate for IUI, what's the next option?
So the easiest patient to counsel is somebody with blocked tubes. We then go on to in vitro fertilization.
Got it.
And that's a standard therapy that we see being utilized throughout the world. I mean, 1978 was the first in vitro baby, and basically 40 years plus, we've learned so much more, and the field has changed dramatically. And I think there's almost 9 or 10 million babies born from IVF worldwide.
It's amazing.
Yeah.
Right. We get asked a lot on the Fertility Answers app, if I have blocked tubes, can I get them unblocked?
Yeah, you could get them unblocked, but quite frankly, it depends on the degree of blockage. If your tube is just mildly, we call agglutinated, where the ends of the tube is just joined together, we can free that open, then that's really very good. But if you have really blocked tubes and the tubes are distorted because of fluid building up in them, you should probably have them removed and then go on to do in vitro fertilization.
Got it. Okay, because there's other risk factors involved that even if you went on to have a pregnancy, that are very dangerous.
Well, and not only that, we know that blocked fallopian tubes, that fluid can transudate back into the uterus, coat the walls of the uterus, not allow an embryo to attach, even if we have an embryo in the laboratory that we're going to place in the uterus.
Got it. Okay, so this is just counterproductive, and surgery is part of the treatment plan. Remove the tubes, and then you're going to be in a much better position for a safe and healthy transfer.
You know, it's quoted in research studies that if you have blocked fallopian tubes and there's fluid accumulating in them, you're 50% as likely to conceive, less likely to conceive with in vitro fertilization and embryo transfer.
Oh, that is, okay. Enough said. That's just not a path that makes any sense to attempt, especially if someone's paying cash for a treatment.
Right.
Yeah, not the right way to go.
Right.
Now, I'm really excited, though, about an emerging technology you've been involved in that is not quite IUI, not quite IVF.
Right.
What is this procedure called?
It's called intrauterine lavage. It's a process whereby if you have open fallopian tubes and your egg is being picked up by the end of your tube and it's being fertilized by sperm, before the embryo implants in the uterus, when it's just coming into the uterus, we can kind of rinse it out of the uterus and then take that embryo and check it for genetic diseases. We can confirm that it's chromosomally normal. You can do gender selection then. You can do embryo banking. It's called intrauterine lavage.
That's really exciting. So intrauterine lavage. Now, do women still go through hormonal stimulation?
They could, and in fact, all the research study that we just completed, we took women and gave them fertility medication to multiply the number of eggs that they were actually producing. And then we went ahead and inseminated them with partner sperm or with donor sperm because these were research cycles. And we used oocyte donors. And then what we did was we then rinsed out the uterus of each of those donors, and we were able to recover embryos about half the time.
That's incredible. And how many embryos do you get in that kind of situation? If you're helping a woman to make more than one embryo, how many embryos can a woman expect?
Well, in the women that we did get embryos, most of them got one or two. You know, incredibly, we did have one woman that gave us 7 embryos.
Wow, that's incredible.
Yeah.
Oh my goodness.
Yeah.
So this is interesting because I think that we, as patients, probably have never considered that there's kind of a window of time where the embryo is kind of floating in the uterus, correct?
Well, you know, the uterus isn't this big open space where the embryo rattles around in.
Right.
The embryo, yeah, that's right.
Yeah.
Well, you know, we draw these pictures like that,
Yeah.
but really the walls of the uterus are touching one another.
Sure.
So there's this time when the embryo comes into the uterus, it's kind of nestled between the walls, it's not completely implanted.
Got it, okay.
And so what we can do is we can expand the walls out with fluid, kind of rinse the sides of the uterus, and then recover the embryo.
It's incredible. So I'm thinking in the scenario of couples who want to do reciprocal IVF, ROPA, where you have a same-sex couple that wants to use one mama's eggs,
Yes.
right, and then transfer into mama 2,
Yeah.
and then have a wonderful experience where they both got to participate in the development and birth of their child. Is that a good model for this?
It's an excellent model, and it's probably one of the best models we can have, where one woman actually gestates the embryo for up to 5 days, and then we come in, we lavage the uterus, it's a gentle rinse of the uterus, and we take that embryo and then place it back into, let's say, her partner. And at that point, we can do genetic testing on it. It doesn't have to be right away, but then both women have the opportunity to contribute to that pregnancy.
Which is incredible.
Yeah.
And a lot of times these are two fertile women. They have to use IVF because in the absence of sperm, they have to go through IVF or IUI, right, in order to do this. But when they definitely know that they want to take the egg of one mama and the uterus of another mama, then they have to go through IVF because you have to create the embryo.
That's right.
So this is a really unique model because they don't have to be stimmed as much, is from what I understand. So maybe fewer medications are possible?
Well, you could certainly do it with less medications. And right now we're kind of testing whether or not what the optimal stimulation protocol is for those patients. So, you know, stay tuned.
Yeah, okay, great. But you already have success.
Yes. We have already performed nearly 200 lavages. They're primarily been done in Mexico because the catheter that we're using to rinse the lining of the uterus is not approved yet in the United States. We're going to the FDA to seek a experimental permission to actually be able to start doing that study in the United States.
Great, that's wonderful. But you've had a birth, haven't you? Or a pregnancy?
Well, we have 4
right?
ongoing pregnancies
That's
already.
Great. Okay.
And the pregnancy rates are relatively comparable to what we would see with other embryos that are frozen and then thawed and then transferred into the uterus.
That's incredible. So as I understand it, this is a great option for people who maybe are looking for a little bit of more organic option, you know, where they don't want to create the embryo in a petri dish. You know, they like the idea of creating it in the body.
Well, let me give you a little preview. One of the things that we actually studied is if we had the same woman and we had embryos created in the laboratory from that woman and compared it to ones that we've removed from her uterus, the ones from the uterus look better than the ones from the laboratory.
Incredible.
And you would expect, maybe there would be some things that we just can't duplicate in the laboratory yet. And so when we graded our embryos and we had this comparison, it was statistically significantly better to have an embryo that came from an in vivo lavage.
That's an incredible finding.
Yeah.
Now, in the infertility population, can you rule out who's not going to be a good candidate for this?
Well, certainly you have to have open fallopian tubes. Okay, so
anybody who has closed tubes is not a candidate.
And the other thing would be if you have a patient whose partner, the sperm source, does not have a normal semen analysis.
Got it.
I mean, we're asking a lot.
Because you're not doing ICSI.
We're not doing ICSI.
You don't need to find the one good one. This is.
Well, we're obviating some of the negatives of ICSI, right?
Exactly.
We choose the sperm based on a number of factors, but we really don't know that that's the best sperm.
Sure.
And so, in a natural state, where only a certain number of sperm are going to make it up to the end of the fallopian tube and fertilize that egg, there's definitely a selection process.
How long has this technology been under development? Because it sounds like it should have come after IUI was invented, right? It seems like it would have been the next logical thing, and then IVF.
Well, there's been a lot of technological advances that have made this possible, but originally there were trials done in the 1980s of actually doing this. And this is actually in the animal world. This is how a lot of milk cows are produced.
Got it.
Yeah.
Okay. I mean, I feel like everything about reproductive medicine started in bovine.
Yes.
First sperm donor, obviously started.
So there right now a lot of cows that are high milk producing cows are being produced in just this way, where the eggs are being fertilized with sperm, and then those embryos then are rinsed out, and then they're placed in all these other surrogate cows.
I had no idea. Oh my gosh, and surrogate cows even.
Yes.
Okay. Wow, that's just blowing my mind. All right, so it's tried and true in an area of medicine already, and now where you're applying it into the human domain, how far away are we from being able to offer this as a treatment?
Well, currently we're going to be doing some limited trials in Spain because the catheter we're using is approved in Europe.
Great.
So that's one option.
Okay.
The reciprocal IVF couples that you were talking about, those are people that we're definitely looking for in Spain to possibly do this.
Okay.
And then I would say in the United States we're probably 2 to 3 years away from that because we have to do an FDA trial to actually show that this is safe. We believe it's safe, but the federal government is very cautious about approving any new procedure. So that's just definitely the goal. We'll have it maybe 2022, we hope.
What keeps you going? Right, this is a new innovation. You've been in the field for a long time, and you're lit up about it. This is an exciting, opportunity and progress to, I think, help in a lot of unique situations. So what keeps you going? What's your motivation behind it?
When I talk about this procedure, I'll tell people this. Everything we know about embryology in the human is done on embryos that have been created in a dish. We don't have that much information on how the natural embryo actually develops because we've never seen that.
Wow, that's incredible perspective.
Yes, think about it this way. The study that we just performed, we have a little more than about 100 of these blastocysts that were all created in vivo in a woman. Those are the only 100 that are in the world.
Wow.
And so that's what's super exciting.
Yeah, it is. The information that you can get about that is going to be progressive in our field.
I've heard this said a couple of times. The science that we're starting to really uncover is fascinating. We might make some discoveries that would just be overlooked from the in vitro side because it's just a different way of getting your embryo.
Oh, that's incredibly fascinating. I'm really excited to follow the progression of this technology, intrauterine lavage. And I think it's something that all patients should pay attention to for the simple fact that Steve is right. Dr. Nakajima is right that it is incredibly groundbreaking to get new information on embryos created inside the body because we haven't had access to them before.
That's right.
That's kind of blowing my mind right now.
Yeah.
So that science, whether it's for people to do intrauterine lavage or because it teaches us new things about the human body, we don't know. And that's what's so, I think, exciting about our field of reproductive medicine and the thing that patients need to pay attention to. I mean, you're very cutting edge. Great things come out of Stanford all the time. Is there anything that we missed that we should let everybody know before?
Well, just stay tuned.
Exactly.
I'm excited about this, and our major publication comes out in the journal Human Reproduction with all the details, and maybe 1 or 2 months it'll be online.
Okay, great. And when it is online, we will post it on the Fertility Answers feed and make sure that it's widely available. You can also come on to the Fertility Answers app, download it on iOS or Android, ask any question that you have about intrauterine lavage, and we'll make sure that it gets answered by one of our experts who knows this new innovation. I'm really grateful that you could join me. We're signing off from ASRM, and we'll see you on the Fertility Answers app. Thank you.